we're going to talk about the older diabetic person trying to improve the individual's care, and very much more nowadays into individual targets. So in a nutshell, hypos are very common. They're generally not noticed. They're often at night, and these were happening in people with ridiculously high HbA1cs, like 9% in proper units. So asymptomatic, do they matter? Could we just all pop off down the pub? Well, probably not. What Dr. Whitmer and colleagues did in North California was to take Kaiser Permanente subjects and look at them for 15 years, or 22 years, until they're aged on average about 65. And they looked at them for 22 years, and the question was, have you had a hypo? Have you got admitted to hospital or emergency department with a hypo which Kaiser Permanente would pay to treat? And then they left them for a year, and they took anyone who didn't have a diagnosis of dementia and then watched them for 5 years. And what happened? If these people had gone to the emergency department or hospital with 3 hypos in late middle age, it doubled the risk of dementia. And you're going to say, wow, that's North California. Mark Strachan has done similar work in Edinburgh, and he again has shown that hypoglycemia predicts the future development of cognitive impairment. But the other really crucial work from Mark Strachan in Edinburgh population is that he's shown that the higher the alcohol consumption, the better the cognitive function, and we just don't know if this has been replicated in other populations. So we're going to go for drugs. We love doing drugs, and the latest things on the block are sodium glucose cotransporter 2 inhibitors, and that's dapagliflozin, I've misspelled that, dapagliflozin, and 2 more coming along any day now. Basically, they just make your pee sugar. So that's quite handy, and you get 0.6% A1C reduction. And if you want to read all about it, not with to self-cite at the moment, but it's in this journal here. So you give someone an SGLT2 inhibitor and they pee out sugar. And because you're peeing out sugar and calories, you lose weight. And it's linked to sodium. So as you lose sugar, you lose sodium. So you get a 5 millimetre systolic drop in the blood pressure. So that's brilliant. And you don't get hypos from it on its own. And it's not mega expensive for a new drug. It's about £35 a month. So about half the cost of a Seretide and Spiriva inhaler. But the catch for our older patients is you need an EGFR greater than 50 or 60 for it to work. And that will sort of severely limit its use in the older diabetic person. Probably only about 30% will have an EGFR like that. And if people are taking a loop diuretic, you're not meant to give them this stuff because they might dry out like a crisp. And heart failure is 3 to 5 times more common in the diabetic person. You can expect 1 episode of genital thrush per year, so I'd give them a tube of canesten cream at the same time. The license is for type 2 diabetes, but it will work in type 1 and secondary diabetes, and there are a few abstracts showing that. And really at the moment, it's license of dapagliflozin according to NICE is add-on to metformin, add-on to insulin. And I think at the moment I would tend to use it in folk on insulin who are going, whose control is erratic, highs and lows. One recent abstract at the ASD showed if you drop the insulin dose, add in something like dapagliflozin, then the dapagliflozin takes care of the highs and the insulin reduction takes care of the lows. But it's very much new stuff and we're still learning about it. And the thing about these drugs is actually, do they make a difference? And there are ongoing meta-analyses. Every year there's a new meta-analysis released. And in this meta-analysis, which matches all the other ones, you find that co-prescription of a DPP4 inhibitor decreases the chance of an adverse vascular event. So a chance of heart attack or stroke is reduced by 20 to 40%. This hasn't been shown in the recent saxagliptin and elagliptin trials, which did have masses. I mean, saxagliptin SAVOR trial had 16,000 people in it, but it only went on for 2 years. So it's clearly not harming them, it's clearly not giving them heart attacks and strokes, and we just hope it might actually decrease it, but we don't have pure RCT data on that. Now, the common problem, you think, oh, I've got someone on metformin, they're failing, what shall I do now? Shall I go cheap and cheerful, sulfonylurea, £2.50 a month, or shall I whop them with a gliptin, say 30 quid a month? And what Craig Curry did was he took the UK GP database, so these are real UK residents. He took folk that were on metformin, and they were given either a gliptin or an SU by their GP. And it's at the bottom of the slide, so that in the matched controls, so the matched subjects, so 3,500 given SU over 5 years, 71 had a heart attack, 71 died, and those given a DPP4 inhibitor, those given a gliptin, 18 died. So, and bearing in mind, you're probably going to give your gliptin to the frailer people. You know, this is observational data, which has got some matching. It does seem to be that actually adding in a gliptin has better survival than adding in a sulfonylurea. And Craig also showed that on monotherapy, the mortality associated with sulfonylurea use was greater than the mortality associated with metformin use. So this suggests that the gliptins are a much safer group than the SUs. There are umpteen different indications, and initially sitagliptin had covered all the possible indications, and all the other companies are starting to catch up. But they're very, very different molecules, whereas sulfonylureas are very similar molecules, gliptins are completely different. So you probably have to wait 10 years before we see the full range of side effects. There's a new basal insulin around called Degludec, which is ultra long acting. So glargine has a half-life of about 12 hours, but Degludec has a half-life of 25 hours. And it has much less variability than other insulins. So Degludec is less variable than Levemir. Levemir is less variable than Lantus, and Lantus is less variable than NPH, Insulatard, Isofame, whatever you want to call it. So much less variability and significantly fewer hypos. And the other thing is, in an 8-hour window, you can give any time you like. So if people are a bit airy-fairy about taking their insulin, they forget about it, take it a few hours later, it won't make any difference. If you're travelling around the world on the jet and crossing time zones, it's a really good insulin to use. But it's more expensive. So a pack of 5 NPH pens would be 25 quid. Pack of 5 Lantus or Levemir is 40. Pack of 5 Degludec, 70 quid. So it's more expensive. And the other thing to really watch out with Degludec is there's a U200. And if you use the U200 in the pen, as you properly should, you've not got any problems. But we find that you go onto the wards and people are drawing the insulin out of the pen with a syringe because they haven't quite worked out how the pen works. And then if you actually give the insulin as you think on the dose on the pen, you'll give double this dose because it's double strength. Okay, so that's Degludec. It's for use when you've got very variable control, particularly if there's hypos overnight. Moving rapidly on to dementia. So if you have diabetes, I'm afraid it doubles or trebles the risk of dementia. And it's really important in the older diabetic person with dementia to make sure they're not hypoglycemic, particularly at 3 o'clock in the morning. Check they're not B12 deficient, because metformin doubles the chance of B12 deficiency, and the usual bits and bobs. And with these people, because of their variable eating, you want to make sure they're not going to go hypo, and you might want to switch them from treatments that do make people hypo, like insulin and SUs, to things that don't make them hypo, like liraglutide or gliptin. And then you need to know whether they're type 1 or type 2 or secondary diabetes. So you've really got to know what sort of diabetes they have. So that's dementia in a nutshell. Neuropathic pain. Neuropathic pain is exceptionally common. And you want to make sure they've not got the usual lack of B12 or thyroid or vitamin D. And we don't have great data, I'm afraid, but vitamin D optimization is as good as any other treatment. So you might want to slug them with duloxetine, pregabalin, gabapentin, whatever, but actually optimizing their vitamin D level is just as good and less side effects. And I feel that if folk have got swollen ankles, that does tend to make the neuropathic pain worse. And one needs to remember that gabapentin and pregabalin in 10% of folk give them awful ankle edema. And when I see people with neuropathic pain, I aim to make it bearable, because if you try and get rid of the pain completely, then they become semi-conscious with the side effects from the drugs.